Welcome to Dementia-Friendly Prince George's County, Maryland Northern Sector webinar series for caregivers. Today's topic is Understanding Supportive Care in Hospice, sponsored by Prince George's County Government and the Department of Family Services.
Hello, everyone. My name is Jessica Whittemore. I'm a clinical social worker. I work for Chesapeake Supportive Care, which is a palliative medicine company. We're under Hospice of the Chesapeake. And I'm really excited to be here today, just kind of talk to you guys about how supportive care and hospice care can really support individuals with dementia and also their caregivers. So differentiation between the two terms, right? Because I think people hear the words hospice and palliative and think they're the same, think that, have a lot of questions about it. So supportive care and palliative care are kind of interchangeable terms at this point. Palliative medicine is a medicine specialty. And it is symptom-focused care, and that can be provided to patients and families anywhere on the spectrum of their illness, right? So if you get diagnosed with a chronic illness, a provider should mention the word palliative care to you, because it's a really hard journey, and palliative care is there to be an extra layer of support. So people are on service for years, and it's delivered kind of in conjunction with curative and aggressive treatments. The next step up from supportive care is hospice. And how I like to differentiate palliative and hospice care. Palliative care is an approach to medicine. It's a medical approach. And hospice is an actual service. So hospice is for someone, if the disease follows the expected course, we expect a prognosis of 6 months or less. Typically, patients are often referred late, and we'll talk about that a little bit later on, just in terms of hospice myths and things like that, because it is meant to be used for 6 months. And that's one of the goals of supportive care, which is the step before hospice, is to make sure you get on hospice when it's time appropriate. Myths and facts about palliative care. So myth number one, palliative and hospice care are the same thing. So I kind of talked about that, but I wanted to just go over it again, make sure nobody has any questions. While they have similarities, they are not the same. And I always like to tell people that hospice care is palliative in nature, but palliative care is not hospice. Hospice care is a form of palliative care, because remember, in our previous slide where we talked about the definitions of palliative and supportive care, that is about symptom management. And that's something really important to hospice, is managing those symptoms. But hospice is a service, 6 months of life or less. And like I said, palliative care is throughout the duration of the illness. So who is eligible for supportive and palliative care? It's a good question, and I'm going to answer it for you. So individuals with life-limiting illnesses who may still be seeking curative treatment, individuals who have chronic conditions that require aggressive pain management and symptom management, and an individual may not have a terminal prognosis. So really, who is supportive? There's a lot of words to basically say anyone who's diagnosed with a chronic or life-limiting illness. Anything that is going to require more care than just, your average healthy individual. So if you get that chronic illness diagnosis, we'll definitely evaluate you for supportive and palliative care. How do you know if someone should be considered for supportive and palliative care? More good questions. So we have some examples. And like I said, so that's our first step, right? You've got this chronic illness diagnosis. How do we know if you need supportive or palliative care after that? One of the things we look at is your health condition steadily going downhill? a physician wouldn't be surprised if you might die within the next year based on your disease trajectory, right? Another big one we look for is frequent hospital admissions for the same condition within several months. So if you or a loved one is constantly going to hospital for the same issues, it would be time to consider supportive and palliative care, because one of the goals of supportive and palliative care is to be proactive and treat those symptoms that are leading to hospitalizations before it happens, so you can stay at home with your family or loved ones wherever you may be. And when I say frequent hospital admissions for the same condition, I don't mean every other week. I mean, I really think of it as 3 or more in a 12-month span. So if you go to the hospital 3 or more times in the same year for the same condition, definitely appropriate for supportive and palliative care. And I know 3 doesn't sound frequent, but think about when's the last time you went to the hospital. So it's 3 in a year is a lot, very disruptive to our lives. So if someone has any complex, difficult symptoms or psychological needs, so anybody where your team is just kind of all over the place and you've got a specialist for this and a specialist for this, and it's very complex, they're totally appropriate for supportive and palliative care. Significant decline in their functional status, that's something we really look at, because generally when we have a significant decline in our functional status, our health is declining as well. They go hand in hand. No history of advanced care planning, limited social support, and or a limited prognosis. So I want to go advanced care planning. So I know I have said palliative and supportive care, we kind of focus on 2 areas, and those are symptom management and goals of care conversation. Those goals of care conversations can be really hard to have, but they're also really, really important to have. So it's really good to talk about these things before your health declines. So how can supportive care help with dementia? Another great question. Supportive care can help throughout the progression of dementia by having in-depth appointments where the supportive care provider spends the time to get to know the person, not just their dementia diagnosis. So that's super important. I would say our providers spend anywhere between 50 to 90 minutes in the homes. So that's number 1. We're going to the house to see people, which is my second bullet point. We're those eyes and ears for a lot of those providers. With dementia, it is a progressive illness. So people do decline, and situations are very different. It's harder to get out of the house. So again, we're going to the house, we're being those eyes and ears, we're offering our medical professional perspective throughout the entire journey of the illness, through all the different stages. Those in-depth appointments are really important. I don't know about you guys. I know for me personally, when I go to my doctor's office, it's like 10 minutes. And I tell them what's wrong with them, and then there's like, well, here's a prescription, bye. And I feel like I don't really get a lot of answers. Sometimes I leave more confused than before. And having dementia is so difficult, not just for the patient, but for their caregivers and their providers, their family, their friends, who's ever helping care for them. And so it's really important to have those in-depth appointments so that 1, we can help guide you in the best direction. 2, we can really get to know, your loved one as well as the caregiver. And when we know you better and we know your baseline, we know when we see a change in that behavior and when we can talk about other things. So our team is also interdisciplinary. We have the social worker, which is me. We also have a chaplain for any spiritual support. Palliative and supportive care is really looking at the whole person. physically, spiritually, and mentally. And that's, the best way to do it. You gotta work with the whole person and the whole family. Um, so I'm gonna just talk about how supportive care can help an individual who's been recently diagnosed with dementia. So we're talking about those early stages, um, families noticing differences, things like that. How can we help during those early stages? So one, I want to talk about, I talked about this way, way long ago in my earlier slide, but a lot of people are referred to hospice late. A lot of people are also referred to palliative care late, and palliative care can really be started as soon as you get diagnosed with a chronic illness. Because having that chronic illness, there's going to be a lot of ups and downs on this journey. So we all know what the early stages of dementia. I personally think the early stages are one of the harder stages, just because typically someone with an early stage of dementia is aware that they're diagnosed with dementia, but their cognitive mentality is kind of going in and out. It's waxing and waning. So it's hard for them to come to terms. It's very emotional to know what's coming down the pipeline. One of the other things about early stages of dementia, sometimes it's really hard to catch that early stage. Families attribute it a lot to, well, they're just getting older, they're just forgetful. So they don't really dig into what's about to come. So having help at the early stage is really important. So the case that I want to talk about is this one patient we had, lovely, lovely woman. And what was so important about her in these early stages is she lived alone. She did not have any advanced directives done. Her family, the closest family member, was maybe an hour away. And so they didn't see her that often. Having palliative care come in really helped us get to know that patient and find out what was important to her before her illness progressed. It also helped us work with the family to determine next steps and a really good plan for this patient. It's really important to make an appropriate plan in advance, because when you don't, then things change. There's a decline and you need things in place, but it's rush, rush, rush. So it's not as quality as it can be, right? It's just whatever we can find. But when you have someone coming to see you regularly who's talking about these plans, do you want to stay at home? Do you want to go to an assisted living? Do you want to move in with your family? Do you want to hire caregivers? And talking about which is realistic financially and emotionally and spiritually, like which one's going to work for you, is really important. The other early important part of having these visits in the early stages of dementia is that advanced care planning. It's really hard for caregivers to watch this happen to a loved one. And it's also really hard for caregivers to make those decisions about when do we stop aggressive treatments? When does that stop? And every human being has their own thoughts about when they want to stop aggressive treatments, about when they want to kind of move towards the hospice scenario where you're really focusing on symptom management and quality of life rather than quantity of days. So having these conversations early while our loved one can still participate is important, because it helps us respect the wishes of our loved one, but it also, for caregivers, it helps take that off of them, right? They're not going to be stuck making those decisions for their loved one. Their loved one already made those decisions for themselves, and you're just there to help see it through. So that's why it's really, I think, really important in early stages of dementia. That's when we can really start our planning, really getting a good baseline, and really following throughout the duration of the illness. A supportive care approach, this is just kind of how we approach things. We really want to elicit your story. We do share medical opinions. We discuss decisions and we make recommendations. Um, and again, an average supportive care appointment can take over an hour, especially our initial appointments, because we really want to get to know you. Our team's not just asking, do you have pain today? How are you sleeping? We do ask all those, and we'll ask about pain first, usually every time. But we're also going to ask, what did you do for a living? How did you and your husband meet? How many kids do you have? Who is in your support network? Who do you consider a support? And we're also going to ask our caregivers that too. Who do you have in your support system? So it's a very different approach than a typical just doctor's visit. But we will do those medical opinions and we'll discuss decisions and make recommendations. So that is a big part of it, but it is so much more. So some examples of how supportive care can help dementia symptoms and treatment. So the first one is no longer remembering to eat. So sometimes that happens. And I wouldn't even say sometimes, almost all times at some point, dementia is going to progress to that point. Your brain's just not firing right, and you're not going to remember how to eat. A big one we see is not just not remembering how to eat, but not remembering to swallow. Your muscles aren't able to do that function anymore. So when an individual can no longer eat, families will need to make decisions about artificial feeding. A palliative specialist can help understand the risk versus benefit for this type of medical intervention. So that's really important. Artificial feeding is not a super easy process. A lot of people don't know that. I think no longer remembering how to eat is one of the hardest symptoms for caregivers to watch their loved one go through. And that's something that a palliative care specialist can really talk to families about. Because what I hear all the time is, I don't want to watch my loved one starve to death. And nobody does. That's like terrifying to think about, right? Like, oh, I can't even imagine. So having someone who is more of an expert in that area to talk to you about what artificial feeding means, and that it's a surgical placement, in talking about what the risks versus the benefits are. That's one of the main things we focus on, is risk versus benefit. And is the risk worth that small benefit or not? And if it's not, what can we do? And also normalizing these symptoms, and letting people know this is part of the progression, and we're going to be here to make your loved one as comfortable as possible. We're not starving them. Their brain no longer remembers how to eat because it's shutting down and it doesn't need food. Slow progression of dementia sometimes make changes in condition hard to see. This one is so true, because when you're in that day in and day out, it's hard to see those small changes. A challenge for caregivers is they start to accept deterioration as a new normal. Palliative care can be the additional layer of support to monitor the progression of the disease. So I think that's really important. Remember when I said when we were just talking about in early stages of dementia, no longer remembering to eat is important, because if this was initiated in the early stages, we would have had advanced directives done and really talked about what your loved one would have wanted. But also, that slow progression of the dementia that makes changes hard to see for family members who are there day in and day out. We're coming usually about once a month, sometimes more, sometimes less, just depending on your need, but on average once a month. We can really see some of those small changes before you can, and we can say, this is what we're noticing is happening. Let's talk about what this means in terms of disease progression. The next one is stress and burden of a caregiver. Stress and burden of care over time on a caregiver. So caring for someone with dementia is extremely stressful. I don't like the word burden so much because, it's not always a burden. Caregivers, some caregivers view it that way, but a lot of caregivers are there because they really want to support their loved one. But it is so stressful. It's exhausting physically, mentally, emotionally. It is hard. And anybody who tells you it's not hard is lying to you. It's extremely hard. A supportive care team can really support and guide caregivers with navigating the health system. That's a very short statement for what palliative care can do. Our goal is to not just help our patients, but to help their caregivers. What can we do to make things better, easier for you? Can we help you obtain resources? Can we provide you with therapy? Can we provide you with support groups? Can we provide you with knowledge and education on the disease progression? Yes, we can do all of that. It definitely does not take away all the stress of being a caregiver, but it can help because sometimes you just need someone who knows what's going on and can help you access things, help you get it. When you're a caregiver day in and day out, and then you have to navigate the healthcare system on top of it, it's just too much. So how does supportive care help a person with middle stage dementia? So middle stage dementia is really when we're starting to focus on caregivers more honestly. When we see our patients, how does supportive care help? I think this is where that symptom management really comes into play. And that's how we can help someone with middle stage dementia. The symptoms that you see are different in everybody. Dementia is one of those tricky, things where it manifests so differently in everybody. But we see similarities and we can help navigate that with supportive care. We can tell you what to expect. Is this a normal thing? Is this not a normal thing? And help manage those symptoms. I think one of the biggest symptoms we get with middle stage dementia is kind of behavioral issues. People can be very irritable, not sleeping, wandering at night. A lot of times people will have hallucinations and things, and just confuse. I get a lot of mom just packs her bags and says she wants to go home. She doesn't remember this is her home. Those kinds of things. How can we help? So the approach we take in palliative care is we look at things. Is this standard to our disease progression? If it is, let's talk about what that means and how we can deal with that. If it's not, kind of what we see in a normal disease progression, then what's going on? How can we adjust that? A lot of times we'll see increased confusion, and sometimes that's the disease progressing, and sometimes that's a UTI. So having palliative and supportive care there can really help, right? If we have someone with increased confusion, that's one of the first things we'll do. We'll have a nurse come out to your house, get a sample, send it to the lab, prescribe meds if we need to. If we can rule that out and it's just standard dementia progressing, what can we do to address it? And we focus pharmacology. Is there any medications we can adjust, change, take care of? But we also focus on it physically, mentally, spiritually as well. So sometimes we can change our behavior with medications and really help with those symptoms that we're seeing, and that can help. But sometimes it can't, and someone with middle stage dementia is just going to wander at night and keep you up. That's what they're going to do. So where palliative care comes in is, how can we help you as a caregiver manage this behavior, right? What do we need to put in place? Do we need different locks on the doors? Do we need to hire caregivers at night? Do you need to talk about assisted living placements? Do we need to talk about having, other caregivers in the family and friends come over and help you at night so you can get some sleep? So we really kind of problem solve. So supportive care with a middle stage dementia is really focusing on those symptoms, because this is when we're noticing them more. What can we do to help these symptoms so that this person can have the best quality of life? And what can we do to help the caregiver help this person have the best quality of life? And how can we help that caregiver be the best caregiver they can be? So one of the examples, we had a patient who just was doing just that, was very irritable, and somewhat aggressive, which is not normal. His wife was like, he was so sweet his whole life. He's just been the nicest person. I don't know why he's acting like this. He curses at me, says he's gonna hit me, and then he just walks around the house all night, and I haven't slept in days. What can we do? Um, and she called us, and we came out, and they were already on our care, so we knew them pretty well. But she had just been dealing with us for a week of this kind of behavior change. And we really just had to sit down and have a long discussion about the progression of it. We talked about sleep hygiene, how we can kind of change, it's to help the patient sleep better at night, and stay awake more during the day. Sometimes that helps. Our provider did prescribe some medication that was actually a really big help to that family. And we also talked about different resources, so that the patient's wife could get some help at home. They did not have money for private caregivers, but we encouraged her to seek out help from their kids. They had 5 kids, and the kids thought everything was hunky-dory over there at home and thought mom was doing a great job. Meanwhile, mom is becoming so exhausted because dad is just walking around in the middle of the night, and she's worried about him, and he's cussing and that kind of thing. So we talked to her that this is kind of a normal part of the disease progression. It's not personal towards you. And you have these great kids, all who live close by. And we had a conversation with her about how to have a conversation with them. And she was a little bit nervous about it. So we offered to do a family meeting, and we had all 5 kids there, and mom and dad, and myself, the social worker, and our nurse practitioner as a team. And we said, this is what's going on. And the kids were like, oh my gosh, mom, why didn't you tell us? And so they worked it out. That the kids would come over, and one would spend the night every other night or so that mom could definitely get rest. So between adding the kids helping out at night and a different medication, the patient became more comfortable, was not as irritable, not walking around at night. And the patient's caregiver was able to get some rest finally. She was so sweet. She just didn't want to worry her kids, but her kids said, we're here to help you. So that's another big role supportive care can play, is encouraging these family discussions, and having them in a safe way, because they can be kind of scary to have. What can I expect from supportive care? This slide shows full of great questions. So supportive care can provide relief from symptoms such as pain, shortness of breath, fatigue, constipation, loss of appetite, and trouble sleeping. So that's just a very small snippet of symptoms that we manage, and just a small snippet of it, because again, one of our number one goals is to manage those symptoms. The better your symptoms are managed, the better your quality of life is going to be, whether you're in palliative care or not, just in life in general. So supportive care can help you carry on with your daily life, improve your ability to go through medical treatments. This one is really important for people to know, I think. So when we go back to kind of like those myths and facts about supportive palliative care and hospice, people hear the word palliative care and are like, oh my gosh, am I dying tomorrow? And you're not, but we want to help you manage those symptoms so that you can engage in your daily life. And being able to go through medical treatments, for example, someone with cancer, they have chemo and radiation and things like that. You have to be physically strong enough to go through these treatments. Supportive care can help you get to that point so that you can do these curative and aggressive treatments. Supportive care can help you better understand your condition, your choices for medical care, and help walk you through difficult decisions. That is so, so important. I think having all the choices in front of you, having all the information and knowledge you can have, really lends itself to making better decisions. It's hard to make these very life-changing, hard decisions without all the information. And it's not fair when you don't have all the information because you don't even know you don't have it all. Um, and they are very difficult. And you really need someone in your corner when you're talking about those. What are some specific ways supportive care helps individuals with Alzheimer's? Um, so again, number one, we're going to evaluate the side effects of the treatment. Number two, we're going to monitor cognitive impairment. We're going to address depression, the decline in functionality, incontinence, falls, lightheadedness, hypotension, deprescribing, hallucinations, and psychosis. So those are just some very specific things we help with. I'm going to talk a little bit more about some of them. Evaluating side effects of treatment and the deprescribing really fall in line and I think are really important. Pill burden is real, especially for older individuals. Somehow you just keep getting pills upon pills stacked up and you have all this medication. And that is something that our providers are really good at evaluating is what is beneficial and what isn't. A lot of times there's some really harsh side effects of treatment and we talk a lot about those risks and benefit. Is the benefit we're getting from this treatment worth these side effects? Sometimes it is, sometimes it isn't. And sometimes, only patients and families can decide that. But it's important to address them and bring them up so that you can decide that. Deprescribing, like I said, is really important. That pill burden, especially, I know I talked about it earlier, losing that inability to swallow becomes harder and harder, not having an appetite, not feeling hungry. It's all normal parts of the disease process, right? You just don't have those neurons and sensors firing correctly. You're not getting the sensation of being hungry. You're not getting the sensation of being thirsty. Now you're forgetting how to swallow, but you have 30 pills we need you to take with water, applesauce, whatever it is. That is a huge stressor for many caregivers. And it's also sometimes really stressful for our patients with dementia. Because they don't understand why they're taking all these pills at this point. They just don't want them. So, you as the provider, like, well, all the doctors, said they need to take these. And, a lot of times doctors will add medications without looking at the full list and saying, well, if we're going to add this one, let's take away these. Because, again, sometimes the risks of them is not worth the benefit. Sometimes the benefit is so minimal that the agitation that comes from it, the trying to crush it up, trying to force it into someone, spending 2 hours to get someone to take their medication is just not worth the small benefit of it. So supportive care is really good about evaluating that pill burden and deprescribing. So I know I talked a lot about those. I just think they're really important. But some of the other ones like monitoring cognitive impairment, that's something that we do. Anytime a social worker like me goes out to a visit, we do what's called an MMSE. It's a mini mental status exam. And it's just a quick little test we do, and it helps us and our providers track someone's cognitive impairment. So we can see when things are starting to decline. So the MMSE evaluates things like just specific recall, short-term memory, but it also evaluates like ability to follow 3-step directions, orientation to day and time and things like that. So it can really help us determine where you're at in your dementia and Alzheimer's process. Hallucinations and psychosis is pretty common, and something we see a lot. Supportive care is really good about, addressing that with medication, but also with behavioral changes and supporting the caregiver in it. So letting the caregiver know that this is normal if they're hallucinating, and it's hard for you and scary for you, this is what we can do, right? And just kind of helping you through that whole process. In addition to symptom management, supportive care can help with making healthcare decisions in advance. So I feel like I've talked about that a lot, but I can never talk about it too much. So I'm gonna talk about it again a little bit more in detail. So we're having those conversations about what people want. It's being proactive, we're expressing your wishes, and we're decreasing family stress. When you have your wishes spelled out, it is so much easier for families. So those are conversations we have at every single visit. We can help complete the medical power of attorney. If you can't make decisions for yourself, who would you choose to make those decisions for you? We know with dementia and Alzheimer's, there's gonna come a point where you can no longer make any type of complex medical decision. Who do you want making those decisions? Sometimes it's obvious, my husband, my wife, my daughter, my son, but sometimes it's not. This is just like a little personal aside, but my mom has made her wishes very clear. She says, I don't want any life-saving measures, nothing. I just want to be made comfortable. So I am not her power of attorney because it's my mom. And I was like, I will never pull the plug on you, Mom. So she did not make me power of attorney. She made someone else in our family who is less emotionally involved and able to follow her decisions. So I think having a medical power of attorney is something for people of all ages and all, whether you have a chronic illness or not, just something important to think about. That living will and advance directive. Medical power of attorney goes with an advance directive, hopefully. And that really spells out what someone wants and what someone doesn't want. And the power of attorney, it makes it easy for them. They can just say, well, Mom did not want a feeding tube, so we're not going to do that. She did not want to go through that at this point in her life. And so it just makes things very clear. The most is a medical order for life-sustaining treatment. The most is specific to Maryland. Like in Pennsylvania, they have the POST, the Pennsylvania order for life-sustaining treatment. So they're very similar, but the most is specific to Maryland. It's an actual medical order. It's signed by a physician or a nurse practitioner, and the most addresses more specific wishes for yourself than advanced directive. Advanced directive's kind of general. It talks about things like end stage, terminal illness, vegetative stage, what you would want. The most is for right here, right now. If your heart were to stop beating, would you want CPR? Would you not? Would you want to be intubated? Would you not? And EMS is trained to look for a most anytime they're called out to someone's house. I tell patients, hang it on your fridge, put it by your door, and they follow that. Does this person want CPR or do they not? And if they don't, how can we make this comfortable for them? Oh, look, we're going to talk more about it. So this is something important that I did not mention. If there's no most, the default is CPR. So remember how I said with the most, EMS is trained to look for it. If there is not a most in their home, A lot of people refer to it as a DNR, but it's the most. And if it's not available in your home, EMS is legally required to perform CPR. And that can be very, very traumatic for both the patient and the family. So if a patient has decided, if my heart is to stop, I would not want CPR. I would want to pass away peacefully. It's so important to have the most form done, because watching your loved one go through that kind of pain, um, that CPR does invoke. I mean, it is it's not like it is on TV. It's hard. You gotta break ribs and things to get in there to get that heart started back up. And most of the time it doesn't work, or you end up intubated on a tube, just depending on what your health status is prior to needing CPR. And some people are just so adamant that they do not want that to be their final moments in life. Um, and if that's the case, you really want to make sure you get a most. Any doctor you're working with, any nurse practitioner you're working with can go over it with you and sign it. Um, Palliative care, supportive care, super helpful with it, because that's something we talk about at every visit. You can change your most at any time. So I have a lot of patients who will do one most, and then, 6 months later, things are changing with their illness and they're like, this is not what I want anymore. Or family says, their living will says when they've reached this stage, they did not want XYZ. And then we update the most. It can be changed all the time. And that's why palliative and supportive care following is so important, because we're going to ask you at every visit, is this still correct? Is it not? Do we want to have a discussion about it? Do we want to have a family meeting about it? Where can a person receive supportive care? Really anywhere you are is what I tell people. We're in a variety of settings. So supportive and palliative care, most hospitals should have an inpatient palliative care team, so you can receive it while you're in the hospital. We are a community-based company. We see people in assisted living facilities. We see people in nursing homes. We have an outpatient center here in Pasadena and Waldorf, Maryland, are our two locations. We also have an office in Largo. We can see patients via telehealth, and most commonly we see patients in their home. Especially with dementia, it's harder and harder to get out of the house as you decline. Sometimes it's really confusing and distressing for people to leave their home or to leave their assisted living. And so that's why we see people wherever they are. Supportive palliative care is really good at meeting the patient and the caregiver where they're at. Both physically and mentally. So this is my favorite part, because it's one of the reasons that supportive and palliative care is so unique. Who makes up our team? It is so interdisciplinary. It is amazing. I think everybody should have an interdisciplinary team, no matter what is going on in your life. Because we all know that your mental health affects your physical health, and your physical health affects your mental health and your spiritual health and everything. So we have a big team. It's awesome. The head of the team is really a physician or an advanced nurse practitioner. We also here have a chaplain and a social worker. We have our supportive care coordinators. They work in our office and set up all our appointments. They're who you call to say, hey, I woke up and mom's not feeling well. Can someone come out? We can refer to psychiatrists, psychologists, dietitians, pharmacists. Our medical director is actually awesome because he is a pharmacist and a medical doctor. So he's so knowledgeable, which is so great. We can also order occupational therapy, musical therapy, physical therapy. We have mindfulness training practitioners. Myself, I'm a Reiki practitioner. We can refer to massage therapists. We have a child life expert, and we do have bereavement and grief counselors. So we have access to a lot of things. We can refer to a lot of things when you're on the supportive and palliative care team. you have access to what you need, because they're all involved. You're not going to feel better if you don't have, you know, access to get your medications. You're not going to feel better if your goal is to get stronger without physical therapy. How are you going to do that? How are you going to meet that goal? So we're really here to help with all aspects of everything, spiritually, physically, emotionally. It's great. I think interdisciplinary is the way to go. Myth number 2, it costs a lot of money to receive supportive care. So this is the biggest question I get when I meet new patients. They're like, how much is this going to cost me? So I like to make sure people know that it doesn't work, it doesn't cost anything extra. Supportive care appointment is billed just like any other medical specialist. So, like when you go to your cardiologist for 10 minutes, it's billed exactly the same way as that. So, Medicare, as we all know, Medicare covers 80% of things. If you have a secondary insurance that picks up that 20% copay, you shouldn't have a bill when you see our providers. So it's billed just like a regular medical appointment. People are like, but you come out to our house and you come when we call you and things like that. And I'm like, if they want to make sure it's not like a concierge service or anything. And I'm like, it's just a regular doctor's visit, nothing. Our office is just mobile. So that is one of the biggest myths, and just important to know that we want to make sure everybody receives the care that they need. Myth number 3, if you see a supportive care specialist, you can no longer see your primary care provider. What a lie that is. When you're seeing someone from supportive and palliative care, when you're seeing our doctors or nurse practitioners, you can see any other healthcare professional you want to see. Like I said, we'll refer you to a specialist. We'll refer you to a physical therapist. We communicate with your primary care physicians. So like every time we see you for a visit, our note goes into the computer world and it can be accessed, by your primary care provider. A lot of times, depending on your referral and issues, we're not going to change your meds till we talk to them because they're the ones overseeing it. We're going to work in conjunction with everybody. Myth number 4, hospice is chosen when there is no hope or when nothing else can be done. Also, what a lie, what a lie. Hospice is the something else that can be done. It's a service. It's for patients and families when an illness can't be cured, right? There are so many illnesses and diseases out there that just don't have cure. Sometimes that's life, right? Like we all are going to die at some point. Different for everyone, but hospice is really about getting the most services you can get for yourself. It's not an end to treatment, it's really a shift in your focus. You're changing your focus to be comfort oriented, focused on helping our patients live their life to the fullest. We have people who travel on hospice, doing all sorts of things out there living their life because they're not having to worry about anything. We're here to support them through all of it. So here's a cool little infographic for you. It's about supportive care and hospice comparison. So prognosis, supportive care, you don't need to have any type of prognosis. You just need to have a serious illness. Hospice, 6 months or less. The focus of hospice is really comfort, quality of life, and you're not going to be really seeking any curative or life prolonging treatments. Supportive and palliative care, we are still focusing on that comfort and quality of life, but it's right along with your life sustaining treatments, life prolonging treatments, aggressive curative treatments, rehab, things like that. The supportive care team, medical provider, social worker, and chaplain. Hospice has a much bigger team. Even though our team's great, they still have a lot more resources than we do. You've got your RN case manager coming every week. You got a chaplain. You've got your nurse practitioner or MD heading up the team. You've got your social worker. We've got volunteers that do all sorts of amazing things. And we have CNAs, which is really helpful for people because we all know as dementia and Alzheimer's progress, you eventually become bedbound. So you need things like help with things like bathing, eating, all sorts of stuff. And we do have CNAs that can come out and under hospice and help with those things, help with bathing and changing the sheets to a hospital bed, because that's way harder than it should be. I don't know why it's so hard. That's why we have CNAs to help with it. Access supportive care, we have appointments just like other specialists. You have an appointment. On hospice, you do have regular appointments, but there's also a 24-hour phone line. So if there's an urgent change or anything, you can call us. We're going to send a nurse out at 3 o'clock in the morning if we need to. Supportive care is covered by Medicare Part B or commercial insurances. Hospice is a hospice benefit. With hospice under Medicare, so I know I said earlier, Medicare only covers 80% of pretty much everything. So not just supportive care, but all your other doctor's appointments, hospitalizations, and things. Once you elect hospice, Medicare does pay 100%. So if you don't have that secondary, you don't have that 20% copay. So myth number 5, hospice is a place. Hospice is actually a philosophy of care. It's a service, and it can be provided anywhere, whether it's home, assisted living, or long-term care facilities. We do have an inpatient unit here in Pasadena and one in Charles County as well. They're both beautiful and lovely, but we really can provide our hospice services anywhere that a patient is. And we want to let the patient determine their route of care, whether they want to be at home, at their home or their son's home, or they're in an assisted living and they want to stay in it, things like that. We have routine home care, respite care, and inpatient care. So all different levels. Medicare benefit of hospice is you get 5 days a month of respite care, where you can come and stay at one of our inpatient units or a local long-term care facility that we have a partnership with. So we've kind of progressed. I'm wrapping things up. Sorry if I'm talking fast, but I wanted to go over how hospice and supportive care can help a person with end-stage dementia. So at every supportive care visit, we're really assessing for hospice eligibility. We really have those conversations about disease progression, what comes next, and what you can expect. Someone with end-stage dementia, hospice is really there to help the caregivers. We want to make it so that your loved one is comfortable and cared for, and that you can go back to being their loved one and not their caregiver all the time, so that you can spend that time with them. We also, when someone's on hospice after they pass, we have an amazing bereavement program. It's called the Chesapeake Life Center. They do individual counseling, they do group therapy, they do a lot of fun workshops, yoga and art things. And for kids, we have camps and teen groups. It's really lovely to see, because that's something in the medical field I think is often forgotten about, is, well, what happens next? Who's going to help me through this process? And so someone with end-stage dementia, that's when our palliative care provider is going to refer to hospice. Family is okay with it, and that's the plan, and say, how can we help you next? How can we help you coordinate a funeral? Do you have those things done? How can we support you best? Hospice is so individualized, and hospice will help a person with end-stage dementia by making sure they are comfortable, cared for, but more importantly, they're going to make sure that the caregiver is also cared for and that they're receiving all the help that they need. So when is it time for hospice? That's a question I get asked a lot, people are like, well, is it time? Is it not? And that's why supportive care is so important, because we're there every month, checking on you and assessing for appropriateness for hospice services. So these are some of the things that we focus for when it's time for hospice, when there's no longer a cure possible, when you really want to focus on comfort, symptom management. We really look for that physical decline, dependence on most activities of daily living, weight loss, increased doctor's visits, multiple emergency room visits, things like that. That's when we're starting to talk about, it's time for hospice. The biggest and most important one on there is goal of comfort care. Some people, it's never time for hospice because that's just not their goal and not their plan. But for most people, at some point when they are very dependent on everything and their mind's gone, most people will say, I just want to be made comfortable. I want to be with my family and I want to be made comfortable. And so if that's the goal, then it's time for hospice. And if that's the goal and you're at that stage in your illness, it's time for hospice. But it's really important to flesh out those goals before it gets to that point, because we all know with dementia and Alzheimer's, you have that physical decline where you are dependent, but you also have that mental decline and you're not very verbal anymore. You don't really know what's going on. So if you have supportive care or even just a great PCP who's had these discussions with you, you'll know what your loved one's goal is. Eligibility criteria for hospice. So this is, just kind of bureaucratic things. But to be eligible, a physician or medical director has to do a CTI, which is a certificate of a terminal illness. And they have to say that if if this disease were to continue how we expect it to, we'd estimate you have 6 months or less to live. And we've had people in hospice anywhere from 1 day to 3 years, because none of us have a crystal ball. We don't know. But it's really what we're looking for is that if this disease progresses how we expect it to, that you have about 6 months left. The other important piece is that you are in line with that hospice philosophy, right? We're not looking for that curative, aggressive care here. We're really looking for families and patients who are interested in that comfort care, that symptom management. Myth number 6, hospice is only for people with cancer. I mean, do you guys even think this is a myth anymore? Because I just spent an hour talking to you about how great it is for people with dementia. But, that is a myth. People think, oh, hospice is for cancer. And I will say, about half of our patients are cancer patients. Cancer is one of those illnesses that has a particular pattern to follow, whereas dementia does not. Dementia kind of does whatever it wants. But yeah, hospice is for any significant illness: heart disease, lung disease, ALS, Parkinson's, and it's so it can really go anyway. Any time you have 6 months or less to live, you're eligible for hospice, no matter what that diagnosis is. And down here we have UTIs, pneumonia, broken bones, things like that. I do want to make sure that we know they receive appropriate attention. We do treat illnesses that are not related to your terminal diagnosis. UTI, we can give you an antibiotic and make you feel better. The way we look at it is this something symptom that can be managed? Because UTIs are no fun and we want to help as much as we can. Myth number 7, hospice is only for people who are not willing to fight. Another lie. This presentation is full of lies. Hospice is about living well, working well, building relationships well. Those affected by advanced illness may struggle to come to terms with death. using the gift of time, giving voice to your wishes and desire, and assuring your values are respected. Hospice is actually for the opposite of people who are no longer willing to fight. I think this one where it says using the gift of time is very important. Having that time, you can really spend it with your loved ones and not focus on going to the doctor every day and not getting injections every day, or, that focus is for you to spend with your loved one. What's included in hospice care? We kind of covered that. The team members, that bereavement counselors. So once you're on hospice, you have your physician, your nurses, your CNAs, your social workers, your chaplains, your volunteers. But bereavement follows you for a year after your loved one passes. Also with hospice, you get volunteer support, 24-hour on-call support, and this is a big one. That's when Medicare finally starts to pay for things like medical equipment, supplies, and medication. You'll get any continence supplies delivered, like Depends and wipes and pads, hospital bed if you need it. Anything you need really is included. Why do we focus on hospice care? Again, multidisciplinary. You're looking at the whole person, and we're really optimizing care wherever that patient calls home. Enhanced support for patients and families at the time they need these resources. Hospice care is not just for the patient, it's for the families to make sure they're also getting the support that they need, both while caring for the patient at the end of life and also support after that patient passes. Myth number 8, medication used in hospice care make people die sooner. That's a big one. People really think that, they'll say, are you just going to pump me full of morphine? That is not at all what we're doing. Maybe it was, in older days, but it is not now. Medication is used to manage your symptoms. It never hastens and it does not prevent death. Myth number 9, hospice care is expensive. Most insurances cover hospice care. And I did tell you already that that's when Medicare covers 100%, not just that 80%. Myth number 10, patients must sign a DNR order prior to hospice admission. You don't. You can pick what you want. We'll go over that most at all your visits. So thank you so much for, listening to all this. I know I talked a lot, gave you a lot of information. So here's just our information about Chesapeake Supportive Care, as well as Hospice of the Chesapeake. Feel free to call us, email us, especially if you have any questions or you feel like this might be appropriate for your loved one. Here's how you can do it. Dementia Friendly America, thank you so much for having me. I've loved being able to share this.